Hello everyone, I am Dr. Japji Uppal, Senior Lecturer, Department of Prosthodontics, Surendra Dental College and Research Institute. As we were already discussing about the implant supported prosthesis, now we have discussed about the 5 clinical visits. Coming to the final 6th clinical visit in which we deliver the denture to the patient. Now select the gold screws depending upon the gold cylinders that is used and position them into the channels for the prosthesis. When tightening the gold screws, tighten them crosswise and not in their sequence or order. The gold screws must be tightened equally. It should not be done like one is tightened more and the other is tightened less. It should be tightened equally. If one gold screw is tightened excessively, the prosthesis could be distorted and cause improper distribution of occlusal force to the implant fixtures. Now, it is preferred to temporarily seal the fixed denture so that the screws can be progressively tightened during the adjustment period. To gain a temporary seal, fill the channel with compacted cotton pallets and use gutta-percha to seal the remaining part of the channel. As you can appreciate in this picture, recall the patient after 2 weeks and check the occlusion framework fit of the gold screws and also his or her hygiene maintenance. This hygiene maintenance is very important. After 4 to 6 visits, if the gingival tissues are healthy and the patient has good oral hygiene maintenance, then seal the excess channels permanently. Place a small cotton pallet or gutta percha over the gold screws before sealing the channel with the composite resin. As you can appreciate in this picture, this is the final prosthesis which we have delivered to the patient. Now, again to tell you, this is the fixed cement retained implant supported prosthesis which we have discussed 6 clinical visits and lab steps. Then this is the final prosthesis which we were discussing about. Then comes the implant supported overdentures. This has advantages like it has the minimum anterior bone loss, prevents bone loss, improved aesthetics, improved stability, which reduces or eliminates the prosthesis movement. Then it has the improved occlusion, better than the fixed one. Then decrease in the soft tissue abrasions, improved chewing efficiency and force, increased occlusal efficiency, improved retention, improved support, improved speech, and improved maxillofacial prosthesis. These all advantages are over the normal conventional complete dentures or partial dentures which are removable. Now we are discussing about the implant supported prosthesis. So all these advantages are over the conventional removable prosthesis. Now disadvantages are that in this abutment crown height space is required. Long-term maintenance is must. The attachments need to be changed like O-rings and clips. This need to be relined. Now continued posterior bone loss is there and obviously the food impaction. Overdenture movement. Now, this is the most common complication related to the mandibular overdentures. These are related to the lack of understanding of retention, support, and stability of the overdenture. When a fixed restoration is fabricated on the implants, it is rigid and cantilevers or offset loads are identified clearly. Many precision attachments with varying ranges of motion are used in the implant overdentures. The motion may occur in 6 directions or we can say in 6 planes, that is occlusal, gingival, facial, lingual, mesial and distal. Now moving to the single prosthesis. This is the partially edentulous implant supported prosthesis. In this we use aesthetic cone abutment. Implant is placed, then abutments are placed. Hexagonal screwdriver is used to tighten the screw as you can appreciate in this picture. Then impression coping, utility wax or tissue conditioner is used. Then abutment replicas are affixed to impression coping, cast in the die stone and mounted. Then gold cylinder on the replicas are used. Now for waxing procedure, cast closed in centric relation, then the intermaxillary distance is measured, which should be around 6 to 7 mm. Then conventional waxing is used and the pattern is proved, invested, casted and reclaimed. Now the metal casting is obtained, which is tried in the individual units. Interface the accuracy, then solder the indexing and framework on the abutment. Now perfect framework fit is required and the veneer application is done with the help of opaque or porcelain, then contoured and glazed, and proximal contacts are maintained and occlusion is maintained. Then this is the final prosthesis cemented in the mouth. Now implant supported single tooth prosthetics. In this the abutment design is Serra 1. Now abutment is placed as you can appreciate in this first picture. Then nylon impression coping is used for making the impression. Open window custom tray technique is used. Then vinyl polysiloxane impression material is used. Now resin to secure coping to the tray. Then implant replica on the Serra 1 impression coping is used. Soft tissue conditioning material that is used for the flexible zone. Then utility wax is inhibited coping adhering to the stone. Then finally the cast is poured. Now we obtain or we get the master cast. Then on this master cast, ceramic cup centered aluminum oxide is used with the Serra 1 abutment. Porcelain condensed and vacuum fired. Prolonged firing is avoided and dentine material is fired. After that, the crown is built up with porcelain layering, then glazed after the clinical trial fitting. As you can appreciate in this picture, final tightening of the gold alloy screw is done and cementation is done and hygiene instructions are to be given. Now to conclude this presentation, the correct design and precise construction of the prosthesis after implant placement decides its ultimate success. Thank you everyone. I hope you all have understood little about the prosthesis of the implant. Thank you.